किती वेळ आहे?
मला काय नाही, मी आय कॅन.
ओके, अजून एक 5 मिनिट थांबे. तुमचे स्लाइड शेअर सरांना होस्ट केलेस का रे?
एक मी स्लाइड शेअर करून बघू का? शेअर स्क्रीन.
हो, करा करा करा.
दॅट विल बी द बेस्ट थिंग.
सो वी आर लाईव्ह नाऊ. हा ठीक आहे सर. ही लाईट बंद कर रे वरची. हो हो, दिसत नाहीये. आणि ते प्रेझेंटर व्ह्यू फक्त घे रे.
हा, प्रेझेंटर व्ह्यू घेतला ते बरोबर.
हा सूरज, प्रेझेंटर.
ओके, स्टॉप शेअर करू का? राहून दे सध्या.
2 मिनिट थोडं ऍडजस्ट करू. ती लाईट बंद कर ना वरची. का रे, परत पाठवावं लागते का? ठीक आहे, ओके.
तुला दिसतंय ना प्रदीप व्यवस्थित?
हो, व्यवस्थित दिसतंय. हो, काय प्रॉब्लेम नाहीये.
ओके.
ती सर, ती लिंक पहिली तुम्ही पोस्ट केलेली डिलीट करा. नवीन दुसरी लिंक पाठवले.
ओके ओके
हा, ते डिलीट करा, म्हणजे ते लोक विनाकारण जॉईन होणार नाही त्याला.
ओके.
डिलीट फॉर एव्हरीवन करा.
हो, डिलीट फाईल केलं.
हो हो हो.
काय झालंय, गेल्या 1.5-2 वर्षात रोज एक 50-60 मीटिंग मध्ये लेक्चर दिल्यामुळे आता हो.
राईट, परफेक्ट.
आता ही नवीन दिलेली शेअर करू ना?
हा, नवीन आलेली मी शेअर केली ऑलरेडी सर. SOS ला.
नाही, मी ते अश्विन साठेला
ग्रुपला
बोलला
करा.
होता. पर्सनल याच्यावर करत होतो मी, त्याला पाहतो. चालेल, ओके
ओके. सो उमेश वगैरे आले का?
आणि एक प्रदीप, वन रिक्वेस्ट की थोडस मला कधीतरी रिमाइंड कर आफ्टर अबाउट हाफ एन आवर.
ओके सर.
because my interest mainly is tips for vertebroplasty.
ओके, 9:30
So I will be as a lecture.
हाँ.
I will be covering first medical management, then a bit of touching on the aspects of surgical management, and then going to vertebroplasty. So it will come in last 15-20 minutes. So it should not happen that तोच पार्ट व्यवस्थित झाला.
बरोबर 10ला करतो रिमाइंड तुला. सूरज, बाकीचे प्रेझेंटर व्ह्यू फक्त घे. बाकीचे साईड दिसत नाहीत बघ. नाही रे, तिघ सगळे दिसतात का? तेवढे दिसणारच सगळे. हा ठीक आहे. ते तुला ह्याचं दिसलं, लोगोला येणार ते तिथल्या. लोगो आपलं ऑटोमॅटिक पण तू इथंच येणार नाही ना? ठीक आहे, चलो ठीक आहे. चलो सर, विल स्टार्ट.
ओके ओके, नो प्रॉब्लेम.
सो गुड मॉर्निंग.
स्टॉप शेअर करतो आधी.
नाही, राहू दे सर, राहू दे, काय प्रॉब्लेम.
अच्छा, मला काय वाटलं काय बोलायचं असेल तर
नाही काय नाही.
तुझ्याकडे त्या स्लाइड्स असतील तर 2 लावून टाक, म्हणजे काय जास्त इंट्रोडक्शन तर.
नाही, मी सांगतो ना, वाचून दाखवतो.
चालेल चालेल चालेल.
Okay. So good morning. So I welcome you for the interesting talk on the osteoporotic compression fracture, medical as well as surgical management by Dr. Sanjeev Bhandari. Brief about the Bhandari sir. He was my PG teacher. He was my PG guide at Medical College Solapur. He has done his MS Ortho in 1985 and in 1986. I think he is one of the few person who has completed the DNB at that time. He had a special interest in dustantive endoscopy, endoscopic spine, and also in the vertebroplasty. And also I still remember we have started close nailing at Solapur by following various tricks with the available resources. He has done fellowship in orthoplasty, fellowship with the Jean Destandu for endoscopic spine in France, as well as in USA. He He was an associate professor in orthopedics and PG teacher at Dr. VM Medical College, Government Medical College in Solapur. And he has his own hospital named as Bhandari Hospital in, and as well as he's attached to Ashwini Sarkari Rugnalaya in Solapur. So regarding his personal positions, he was an executive member of the Maharashtra Orthopedic Association. He was also a vice president in the on 2009 and 10. He was also an executive committee member from the Maharashtra side on Indian Orthopedic Association. He is presently there also. He was an organizing chairman of MAOCON Maharashtra Orthopedic Association Conference 2005, which was held at Solapur.
2015.
15, yes, and he has many presentation and publications. So mainly he presented 4 papers at SICOT in Brazil. He had publication in trauma, spine on endoscopic discectomy, then Dustin technique, vertebroplasty, distal radius, and he is a faculty at many state and national conferences. So in spite of that, I still remember you as your teaching passion to the students while doing surgery. So I still remember, ask any question at the time of surgery, you just leave the surgery and used to discuss a lot of things on table. So over to you, Bhandari sir. Thank you.
Thank you. Thank you, Pradeep. So I think you can see my screen.
Yes, sir. Yes, sir.
And you can hear me also?
Yes, sir.
Okay. Thank you, Pradeep, for the nice introduction. I really have passion for my students. And my students are my treasure because I have worked as a PG teacher for nearly 15 to 20 years. And especially in the earlier half, I had very nice students like you, Swapnil Kothadia, Anand Karwa, and many others, Amit Bulande, and many others. So today I will be talking on osteoporotic vertebral compression fractures. That is what we refer to as OVCFs, the medical and surgical management. So I will be talking on 2 parts. The first part is medical management, and the second part is the surgical management, which includes the most favorite topic for me, that is the vertebroplasty and the various tips and tricks which I have developed over last 18 years. As I have given lectures on this in various state and national conferences for sharing my tips and tricks. And also I have had a publication for sharing these tips and tricks. So with this small introduction, as you know, worldwide, 1 in 3 women and 1 in 5 men aged 50 and above have osteoporosis. So this is really the magnitude of this problem. And so it is prudent that we should not miss the diagnosis of osteoporosis. The clinical risk fractures, which are said to be there, the FRAX tool is there, which assesses the possibility of developing osteoporotic vertebral fractures. And in that, they have found out the clinical risk factors as age above 50 years and say about 60 years in men and above 45 to 50 years in female who are postmenopausal. Sex, of course, more common in women than men. The low body mass index, previous fragility fractures, including vertebral fractures, parental history of hip fracture. The patients who are on oral steroids for more than 3 months, smoking and alcohol intake, especially excessive alcohol intake, 3 or more units daily. And then these are the secondary causes of osteoporosis, including rheumatoid arthritis, diabetes, osteogenesis imperfecta, hypoparathyroidism, hypogonadism, malnutrition, malabsorption, etc., etc., etc. So these are all the clinical risk factors, and those who are having these clinical risk factors, we should be on the vigil to find out whether they are suffering from osteoporosis. The best way to diagnose osteoporosis is DEXA scan, though we can have a rough guide from the X-rays of the pelvis as well as the spine X-rays. But there are just the rough guidelines measuring the trabecular pattern, etc. The best guide is DEXA scan. T-score more than -1 is usually said to be normal, while T-score -1 to -2.5 is called as osteopenia. You all know that very well. And the treatment for this subgroup is lifestyle modifications like reducing the alcohol intake, stopping smoking, and exercises, mainly the aerobic exercises, which include jogging, walking, and sports. Also, diet, sunlight, and calcium and vitamin D supplementation if the diet is not supplying these things in sufficient quantity. When the T-score is -2.5 and below that, then we call it as osteoporosis. And in this subgroup, we require specific drugs for osteoporosis in addition to these lifestyle modifications. With this preamble, I will go to the osteoporotic vertebral compression fractures, or the OVCFs. Among all osteoporotic fractures, vertebral fractures are the most common. And you can see the magnitude of this problem of vertebral fractures, because in USA, which is a country which is having about 1/5 of our population, they have found out that there are more than 7 lakh vertebral compression fractures occurring every year. So multiply it by 5, and that is the magnitude in India. And this is a typical vertebral compression fracture, which we can see, and it usually occurs at the dorsolumbar junction, which is junctional zone. Though the magnitude is that high, fortunately, about 60 to 70% of these osteoporotic vertebral compression fractures are silent, and they are detected incidentally on screening. You can easily see in your society and community that there are elderly women who gradually go on developing rounded gibbous or kyphosis. And if you take their x-rays, you will find that they have multiple vertebral compression fractures, but they are all silent. They don't have much complaints. But only thing is that if you find them, then it is definitely osteoporosis, and treat the osteoporosis. The 30 to 40% vertebral compression fractures, which are clinically significant, present with symptoms of pain and disability following a very trivial trauma. The trivial trauma is usually either just slipping on and falling on the ground, or even when a person is sitting in a bus or a car, and the car goes over the speed breaker, and the patient is just lifted up and comes down. And then they develop this type of vertebral compression fracture. So such a trivial trauma is required because the underlying cause is osteoporosis. So this is a common clinical scenario which you may have seen many times in geriatric population, like elderly female with history of trivial trauma. And as it is a trivial trauma, they attribute this back pain to some sprain or something like that, and they have their home remedies first and usually present late. When they present late, they come with severe disabling pains in dorsolumbar junction area with typical accordion phenomena. What is this accordion phenomenon? We'll see later on. So what is the routine treatment protocol for this osteoporotic vertebral compression fractures who present clinically with pain? First is the medical management to begin with. The conservative measures are like strict bed rest, analgesics, physiotherapeutic measures like short-wave diathermy, IFT, even low-weight traction, lumbar traction, etc. are tried. And then extension braces like Taylor's brace or Ash brace. I don't know what is your experience, but in my experience, to whomever I have advised Taylor's brace, they are so cumbersome that the patient usually brings it back and gives it to me. No, I cannot use this. But Ash brace, that is the alimcospinal hyperextension brace, is that way patient friendly and can be given. And of course, along with that, medications to correct osteoporosis is equally important. The pharmacological management, as we have seen, is consists of NSAIDs. Usually in this age group, we use paracetamol, tramadol, or a combination of tramadol, paracetamol to relieve the pain. And then comes the treatment for underlying osteoporosis, which we are going to discuss in detail. Now, medical treatment for osteoporosis, the FDA-approved drugs for prevention as well as treatment, I have shown them variously, like estrogen, then the various bisphosphonates, the raloxifene, which is SERM, then calcitonin, and the most commonly nowadays which is used, and the only anabolic agent is teriparatide, that is the PTH, and then denosumab. So this bisphosphonate group and the teriparatide, these are the most commonly employed treatment for osteoporosis. Now coming to the first, that is the hormone replacement therapy. Because we know that after menopause, there is a deficiency of estrogen. And so post-menopausal women are very likely to develop this osteoporosis. And so hormone replacement therapy has been tried. That is estrogen or estrogen plus progesterone combinations. But the basic drawback is that they have unfavorable risk to benefit balance in older post-menopausal women above 55, 60 years of age. And if at all it is to be used, it is generally restricted to younger post-menopausal women who are at high risk of fracture and also have menopausal symptoms. So they have menopausal symptoms. For that, usually the gynecologist advise the hormone replacement therapy, and it can also be useful for osteoporosis. Second is the selective estrogen receptor modulators, or the SERMs. These are the usually the synthetic estrogen modulators like raloxifene. These SERMs inhibit bone resorption. So they are approved for the treatment and prevention of osteoporosis in postmenopausal women. And raloxifene has been shown to reduce vertebral fracture risk, but reduction in non-vertebral and hip fractures has not been demonstrated yet as per the report given below. So this also will leave it to the gynecologist and usually were not very commonly used. What we commonly use in our clinical practice is bisphosphonates. The bisphosphonates usually act by reducing the osteoclast activity so that the bone resorption is reduced. And so it will lead to increase in bone mass. But it is not an anabolic agent. It does not produce new bone. It just restricts the osteoclast resorption of the bone. There are 3 or 4 different types of bisphosphonates which are in use. First is the alendronate, which is used for the treatment of postmenopausal osteoporosis as well as for osteoporosis in men. And the dose is usually either 10 milligram daily or 70 milligram once weekly by mouth. But we commonly use a weekly dose for dosage convenience. And I will not go into much details of this alendronate because we are all using this. And in postmenopausal women with osteoporosis, alendronate 10 milligram daily or 70 milligram weekly has been shown to reduce vertebral, non-vertebral, and hip fractures. Second is risotronate. Now, risotronate is also approved for the treatment of postmenopausal osteoporosis, mainly in women, to reduce the risk of vertebral fractures. And it is usually given as 5 milligram daily or 35 milligram once weekly, which is more convenient by mouth. Third one is ibandronate. The ibandronate is again used for this osteoporotic women and men, and it is used as 150 milligram once monthly by mouth. So this is a very convenient dosage, and we get a lot of pharmacological products where they are giving 30 tablets of calcium along with 1 tablet of ibandronate at the top, which should be taken on the first day, empty mouth, empty stomach, and then from the next day for 1 month, you should take the calcium tablets. Again, next month, you should take this ibandronate tablet and followed by the calcium tablets for 1 month. So this is a most convenient therapy of for osteoporosis, and so it is commonly used. And then comes the zoletronic acid. The advantage of zoletronic acid is that it is to be given only once yearly. That is 5 milligram intravenously is given over 15 to 30 minutes in 100 ml NS. And then you can start other dietary supplementation, and this will be repeated only after 1 year. Of course, the contraindications for these bisphosphonates are the hypocalcemia, then severe renal impairment, pregnancy and lactation, abnormalities of the esophagus that delay esophageal emptying because they have to be taken in on empty stomach, and the patient has to be up and above for half an hour after taking that. Otherwise, esophagitis or the reflux are very common. And so where there are esophageal abnormalities, it should be, it is contraindicated. And of course, the rare side effects of these bisphosphonates are the osteonecrosis of the jaw and the atypical femoral fractures. Nowadays, we are seeing a lot of atypical femoral fractures which are occurring after 2 to 5 years of this bisphosphonate use. And so it is always said that after 2 to 3 years of bisphosphonate use, you should really stop this treatment and give a treatment gap. Now coming to teriparatide. This is probably the best innovation which we have got recently. I remember about 10, 15 years back, One injection of teriparatide 40, it was costing about 22,000 rupees for 1 month therapy. And so it was very difficult to really administer or advise to take patient for this injection teriparatide, because two things are that cost, and secondly, it has to be taken daily. So patients are really reluctant to do that. But fortunately, now the price has come down to nearly rupees 3,500 to 4,000 per month therapy. And so you can advise this therapy quite commonly. Teriparatide is probably the only agent which is anabolic, that is, forms new bone. All other agents usually stop bone resorption and thus by that way try to increase the bone mass. But only agent which can produce new bone is teriparatide. It is a biosynthetic peptide of human parathyroid hormone, that is a PTH, which is a regulator of bone metabolism. It is produced by using a strain of E. coli employing recombinant DND technology, and its sequence is identical to, this is not very important for us because we are not pharmacologists anyway. The role of parathyroid. The low dose or intermittent therapy with teriparatide is essential for anabolic action of PTH. Means in hyperparathyroidism, we see that there is bone resorption. But when we give it in a low dose or intermittent therapy, then the effect is exactly opposite and it causes anabolic activity. So it is indicated for severe osteoporosis and treatment of postmenopausal women with osteoporosis at high risk for fracture, increase of bone mass in men with primary or hypogonadal osteoporosis, and treatment of men and women who are on oral steroid therapy. The dosage of teriparatide is 20 micrograms administered once daily subcutaneously. The patient usually nowadays comes in disposable pens, and you can just like insulin, you can take it subcutaneously over the thighs or abdomen daily. The patient is taught how to take it and he goes on taking it. The maximum total duration of treatment should be 2 years, that is 18 to 24 months. But to begin with, I always advise about 6 months so that patients are ready to take that. If you advise them to take it for 2 years, probably many will drop out. Patients should, of course, receive supplemental calcium and vitamin D supplements if the dietary intake is inadequate. Now, this slide shows the effect of teriparatide on skeletal architecture. After about 21 months of treatment, you can see how the bone was before starting the treatment and how it has the skeletal architecture has improved, or the BMD, the bone mineral density, has improved over 21 months with the treatment with injection teriparatide, 20 micrograms given per day. Now, recently there were updates about teriparatide versus bisphosphonates. So, how effects of teriparatide and bisphosphonates on new fractures in postmenopausal women with severe osteoporosis. And this chart shows that with teriparatide, there is only 6% new or worsened vertebral fractures were seen, while with risedronate, the incidence was 13%. So, the conclusion was that there is significant reduction in the incidence of new vertebral fractures as well as worsening of the vertebral fractures with teriparatide as compared to bisphosphonates, and new clinical fractures also get significantly reduced. They are better at preventing fractures in patients with severe osteoporosis, and adverse drug reactions were well tolerated in both groups. The contraindications to teriparatide are few, like hypercalcemia, pregnancy, and lactation, but usually these are the problems of old age, so pregnancy, lactation as such does not come into the picture. Metabolic bone disease other than osteoporosis, severe renal impairment, prior radiation, and side effects include headache, nausea, dizziness, and postural hypotension. But in my experience, usually patients don't get any side effects. And if they are ready to take the daily injection, it is the best treatment till now. The last one is denosumab. Nowadays, this denosumab is being advocated strongly because its dose is less. It is so it is a fully humanized monoclonal antibody against rank L. It is a major regulator of osteoclast development and activity, and so it is approved for the treatment of osteoporosis in postmenopausal women and men at increased risk of fractures. For the treatment of bone loss associated with hormone ablation in men with prostate cancer at increased risk of fracture. So these are the recommendations for use of denosumab. It is given as subcutaneous injection of 60 milligrams once every 6 months. That's what I was saying. If you'll advise somebody an injection to be taken every 6 months, then probably he will be ready for that. But of course, I personally feel that teriparatide is much superior than denosumab, and I have not, frankly, I have not used denosumab for osteoporosis still. Denosumab has been shown to reduce the incidence of vertebral, non-vertebral, and hip fractures in postmenopausal women, and its approval for its use in men with osteoporosis was granted on the basis of BMD bridging study. Now, there was one study in 2018 where they had done pre-treatment of daily teriparatide, and then thereafter they had given denosumab therapy. And the results were that there was no significant difference in the bone mineral density at lumbar spine, but both femoral neck BMD was higher in teriparatide pre-treatment group compared to denosumab alone group. At 4 months and 12 months, they have found that if you do pre-treatment with teriparatide and then give denosumab, then the results are better. The challenges and limitations are that use of bisphosphorus, particularly for long periods of time, is associated with increased risk of atypical femoral fracture that we have discussed. And so you have to keep an eye on that all the time. Then osteonecrosis of jaw also we have discussed. There's a risk of venous thromboembolism and stroke with raloxifene. That's why I said these agents we don't use, and usually we leave it to the physicians or gynecologists for this hormone replacement or the SERMs. And despite fracture, this reduction with anti-resorptives, fracture may still occur. So other factors are also very important. Of course, in addition to these specific agents for osteoporosis, dietary calcium, or if the dietary calcium is not sufficient, supplements should be given so that there should be 800 to 1200 milligram of elemental calcium available daily in this age group. High dose of vitamin D nowadays, 800 to 2000 international units per day is being advised. Then calcitriol in frail elderly patients only with known liver and renal insufficiency, because activation of vitamin D occurs in kidney and liver. And if there is really proved liver or the renal insufficiency, then you should give activated form of vitamin D. Previously, everybody was, for even younger patients, I saw that prescriptions were there for activated vitamin D. But fortunately, the things have come down, and nowadays people are advising more of high dose vitamin D rather than calcitriol. And then, of course, lifestyle modification, as I said, like sunlight, exercises, and all those things for osteoporosis are important. As I said, additional lifestyle modification things are important. Like try to increase the low body mass index, that is about less than 19 kg per square meter. For a lady of about 5 feet 3 inches or 4 inches, the weight should be above 50 to 55 kg. If it is less than that, it is better that you advise proper diet under the dietitian. Then, of course, long-term glucocorticoid or steroid therapy should be stopped. Stop smoking, and reduce or preferably stop alcohol intake more than 2 units per day. So coming to the end of the conservative or the medical management of osteoporotic vertebral compression fractures, usually 60 to 70% patients respond favorably to this conservative trial of rest, physiotherapy, breast support, and medications. But in roughly 1/3 of patients with osteoporotic vertebral compression fracture, this medical management fails to relieve the intractable pain and disability within 3 to 6 weeks, and it may even worsen with increasing collapse of the fractured vertebral body, and sometimes typical non-union with a IVC. We'll see what is the IVC, that is intravertebral cleft, may occur or may develop. And these have been some predicting factors about further collapse, whether it will occur or not. The upper line shows either concave or dented type of concave or dented type of vertebral compression fracture. And these have been said to have good prognosis, while the swollen, the bow-shaped, and the projecting type, they have poor prognosis, and these type of vertebral compression fractures usually progress to further collapse and non-union. Another study showed this risk factor for the collapse, that is height loss more than 15%, kyphotic angle more than 10 degrees, and presence of intravertebral cleft sign. That's what I was saying, IVC, intravertebral cleft sign during the follow-up. We'll see this intravertebral cleft sign in further presentation. And so in all this subset of patients of about 1/3 of these OVCFs, we may require surgical management when they are not responding to the medical management. And now we'll go to our second part of the talk, that is the surgical management of osteoporotic vertebral compression fractures. Pradeep, may I interrupt in between? Hello?
Yes, sir.
Yeah, is any doubt is there up to now? You want to get it cleared? Then we can talk here. Otherwise, we'll have question answers at the end of the talk. Hello. Anyway, so we'll now go to the surgical management. I think you can listen to me properly.
Yes, sir. Yes, sir. No problem.
Okay.
Sir,
So now we'll.
MRI for this patient. MRI.
I'm not listening to you properly. So we'll talk at the end of the thing.
Okay, sir.
So now going to the surgical management of osteoporotic vertebral compression fracture. This is the case which I showed in the beginning, where the patient had presented late with severe disabling pain. This is on August 2018. And this is the IVC which I was talking about. This is the IVC, that is the intravertebral cleft. And as time passed, the pains did not reduce, rather they worsened, and more disability was there after 4 weeks. The patient was not able to walk or sit, and she was brought in a lying down position. And then the dynamic lateral access, that is in flexion and extension, were taken, and they showed that there is a complete collapse of D11, which is called as the vertebra plana, and while D12 had further significant collapse. Now we'll talk about one more case. This case I saw just 2 days back. The lady had a fall, trivial fall, in on 7th or 8th of November 2022, and this was an X-ray taken locally. It did not show much, hardly very minimal compression of this D11 vertebra. But she continued to have pain, and when she presented to me on 6th of December, that is 2 days back, you can see that there's a very typical intravertebral cleft. That is the upper part of the vertebra and the lower part of vertebra are separate, which are, and you can see it much more clearly in the extension X-ray. So this is a non-union. The upper part has not united with the lower part, and in between there is a gas shadow which is in, but it is actually filled with a non-union fluid. It is just like a non-union of a long bone. And so the two parts of the vertebral body are moving separately, and that's why the patient develops what is called as the accordion phenomenon. On lying down, when she tries to get up, this opened up vertebra tries to collapse, and so patient has pain. When again the patient tries to sleep from the sitting position, the vertebra opens up, and again the patient has pain. So this is called as an accordion phenomenon, just like an accordion. And so this is a very typical of non-union of a OVCF, or osteoporotic vertebral compression fracture. As I said, this is the IVC, or intravertebral cleft. This is the third case. This was there was a fall at home 3 weeks back, and the X-ray was taken elsewhere 5 days after fall, and conservative line of treatment was given. But the patient did not get any relief. And when she presented to me, there were severe excruciating pains, no neurology. This is very important. In all these osteoporotic vertebral compression fractures, you will not see neurology, which is very common when there is a vertebral fracture at dorsolumbar junction in a young patient who falls from a height of about 20 to 30 feet. Usually the bone pieces, fragments get displaced posteriorly, compress the cord, and the patient presents with paraparesis or paraplegia. But this is not the case in osteoporotic vertebral compression fractures. Usually there is no neurology. And this lady was a known case of chronic kidney disease and ischemic heart disease. Now this was the X-ray at 3 weeks after fall when she presented to me, which showed this IVC or the non-union sign on in D12 vertebra with further collapse. And now you can see how much pain she is having. She cannot get up without a support, and there's a lot of pain. She is crying out with pain when she is being asked to sit even in a lateral position. She was not able to sit up in a straight position at all. And then I will discuss one more case scenario. This 62 years lady, she was that way physiologically good. She had undergone treatment for CA cervix and had fall 5 months back. When the X-rays were taken locally, there was, you can see this D12. There was no obvious fracture at that time, but the patient had a lot of pain and the pains persisted. So when she presented to me after 5 months, I took the flexion extension X-rays, and I could see that there was a definite non-union of the D12 vertebra with the intravertebral cleft in between. Now here, one more dilemma is there, that whether this vertebral compression fracture is due to osteoporosis or whether there are secondaries from her CA cervix which are causing this D12 vertebral body to collapse. So this one more dilemma is added to this thing, and we have to solve this thing. And this is all what we can do by vertebroplasty. So for these and many such elderly patients with vertebral compression fractures having significant disabling pains, usually without any neurology in lower limbs, and who are not responding to conservative line of treatment, which we have discussed in detail, what are the treatment options? And the various treatment options, the treatment option first is surgical management. And the various treatment options which we'll be discussing is the vertebroplasty, balloon kyphoplasty, and a major instrumentation which we usually reserve for a young patient with neurology. The aim of treatment in these patients is mainly pain relief with improvement in quality of life, and not exactly kyphosis correction. So a major spinal instrumentation is usually not indicated in these patients, as the posterior neural compression and lower limb deficit is mostly insignificant in majority. And also major surgery may be fraught with practical problems. One is the problems for anesthesia due to multiple comorbidities. And we have to operate in a prone position for about 2 hours or 3 hours. And this is really problematic for anesthesia. Also, the bones are porotic, and so they have poor hold for any spinal instrumentation. Then we have to use really cement, etc., for having good hold of these pedicular screws. And majority patients and caretakers are usually not ready for major surgery because the patient is not having paraparesis or paraplegia, and so they are not ready to take such a major surgery for their patients. So usually for major surgical instrumentation is very rarely needed, in my opinion. And for such patients, percutaneous vertebroplasty, what I usually refer to as PVP, offers a minimally invasive, safe, and at the same time cost-effective modality of treatment with gratifying results. Because a major surgical exercise will definitely cost more than 1 or 1.5 or 2 lakh rupees. But this percutaneous vertebroplasty is much cheaper than these major surgical instrumentation. Multiple minimally invasive treatment options have been described by various authors. But the most commonly used ones are the vertebroplasty and the balloon kyphoplasty. What is vertebroplasty? Percutaneous vertebroplasty is the most commonly used minimally invasive modality for this OVCFs. Vertebroplasty involves the structural reinforcement of a fractured or collapsed vertebral body by percutaneous, this is very important, by percutaneous transpedicular injection of a filler material like bone cement into it. The alternative modality of balloon kyphoplasty involves introducing a needle through the one of the pedicles. Then through that a balloon is inserted inside. This balloon tamp is inflated to jack up the collapsed vertebral body. Then this balloon is taken out, and in the space created, the filler material like cement is introduced. So just an overview of osteoporotic spinal fractures, where there is non-union and intravertebral instability without any neurology, either vertebroplasty or some people like to do mini open vertebroplasty. This vertebroplasty can be IITV guided or CT guided, but all these days nowadays all done under IITV. While if there is neurogeny, very rare subset of these patients, then you can think of major surgery, which is transpedicular decompression and fixation. And you may require about 2 levels below minimum for having a good hold. So about 8 pedicular screws and rods, which is really a very major surgery. Now, this was a meta-analysis published in Indian Journal of Orthopedics in July 2015, where this was a review article of this meta-analysis, which compared PVP with balloon kyphoplasty. They had included 11 studies out of more than 700, which met their inclusion criteria, and totally there were 789 patients. About pain relief, you can see that the VAS pain score was 67.8% after kyphoplasty and 70.5% afterwards. So there is no major difference. Rather, it is better with vertebroplasty. The pain relief is definitely better with vertebroplasty. And coming to the complications, the first complication which is usually reported is cement leakage. But there was no significant difference between these two interventions, that is the PVP and balloon kyphoplasty, as per this meta-analysis. I had my share of cement leakages, especially in the earlier part of my life when I had not developed these various tips and tricks, which I have developed over the years with my own experience. And I remember last 8 to 10 years, I never had any cement leakages with these steps. And these are the steps which we'll be discussing shortly. So I had this posterior spillage, which is a dreaded complication because it can really irritate the dura or the nerve roots and cause some neurological complications. So this was a 55-year-old lady, and there was only 8 days old fracture. Usually it is recommended that you should not do before at least 3 weeks of the fracture. But this lady insisted so much because she was having such a severe pain that I had to do this thing. Previously, I was doing it through a single needle, and this was the posterior spillage, which you can see here. But still, immediately post-operative, you can see that lady very comfortable and 15 days follow-up. And in the end, I will show also the lady at 8 years follow-up without any neurodeficit in her lower limb, even with the posterior leakage of cement. This is the paravertebral leakage, lateral leakage. There was a hematoma problem. Again, this was a 10 days old fracture. The patient insisted there was a lateral hematoma, as you can see on the MRI. And the cement leaked into this lateral hematoma, and still the patient did not have any problem. Anterior leakage in this D12 vertebral fracture, and see the patient comfortable. This was pre-procedure where she had to be supported, and post-procedure she is sitting and walking normally without any problem because of cement leakage. And then this is a leakage of cement into the intervertebral space. So I had said I had the share of cement leakages in all possible things, especially before 2012, 2013. But in last 8 to 10 years, I don't remember whether there was any leakage or not. And even though these leakages occurred, usually with a single needle technique, there was no clinically significant problem in these patients. This is the post-operative X-ray. You can see the cement leakage in the intervertebral space, but the patient did not have any problem. Another complication which is discussed is the subsequent adjacent level fracture. But this meta-analysis says that these two interventions had similar risk for subsequent fracture. Now, this is my one. Many patients have come to me for other problems after the vertebroplasty, 2 years, 4 years, 5 years, even 8 years after fracture. And fortunately, I have not seen any subsequent level fracture, except in one patient, but it may be because of osteoporosis, not because of vertebroplasty. So this is 4.5 years follow-up, but there is no adjacent level fracture. So vertebroplasty in itself should not be blamed for adjacent level fracture. And then again, deformity correction, because one of the things people insist that who actually advocate surgery that you have to correct the kyphosis. But it has been shown by these various articles that deformity correction or the kyphosis correction even occurs with percutaneous vertebroplasty. So what is the major determinant? The major determinant between the balloon kyphoplasty and the percutaneous vertebroplasty is the cost. This article says that average material cost for vertebroplasty in the USA were $300, while for kyphoplasty it was 10 times more, than $3,000. I'll tell Indian scenario. Usually the material cost for vertebroplasty are hardly 5,000 to 7,000 rupees. While for kyphoplasty, when I last knew it about 5-10 years back, it was costing more than 1.5 lakh to 2 lakh rupees for that balloon, which is disposable. So I tried to advocate it to some patients in the beginning, but total 2 lakh rupees of expenses, nobody was ready. So I have not done a single balloon kyphoplasty, and I'm totally happy with percutaneous vertebroplasty. So because of all these constraints, percutaneous vertebroplasty is the most widely preferred modality. What are the major advantage of vertebroplasty? The main important thing is that there is immediate relief from the disabling backache. Patient may be suffering for 3 weeks, 6 weeks, 2 months, 3 months, 6 months. But in 10 minutes or 15 minutes after vertebroplasty, the patient, once the cement settles, there's immediate relief from the disabling back pain. It gives stability to this unstable vertebra, thus restoring mobility and preventing further collapse, as well as this accordion phenomenon is totally gone because it gives stability. Main important thing is that it is a minimally invasive technique, and I am doing this under local anesthesia over last nearly 18 years. In only one case, I remember I had to give a GA because the patient was very, very apprehensive. Otherwise, all remaining cases, more than 350 cases, I have done them under local anesthesia. And in this geriatric patients, this is the major advantage, that it is done under local anesthesia and it is minimally invasive. 2 or even 3 level can be injected at one sitting. You can see here that I am injecting 2 levels at one sitting. And in suspected cases, that lady we saw who had a CS cervix with this vertebral compression fracture, we can take a core biopsy to rule out whether it is a metastasis or whether it is an osteoporotic vertebral compression fracture. With all this discussion, I am really sorry to say that vertebroplasty is still much underutilized technique. There are so many patients who are suffering with this painful vertebral compression fracture, but it is still very underutilized technique because there is an unjustified fear of complications like inadvertent injury to dura or nerve root during needle passage, cement leakages, especially posteriorly into canal, causing cord or root irritation or adjacent level fractures. And we have already seen that these are usually less than 10%. Main important is they are clinically asymptomatic and transient, and most importantly, they most important is that they are avoidable with due care and the steps which I will be elaborating in the further presentation. So after performing more than 350 vertebroplasties over last 18 years, I started that in 2004. I'll be sharing tips and tricks for successful vertebroplasty. This is the main part of my talk, and Pradeep, I think I will get 10 to 15 minutes for this. First and foremost thing is that you should take dynamic flexion and extension lateral X-rays and MRI, especially in old fractures, because this will show you whether there is an intravertebral cleft is there or not, and the MRI will show a fluid shadow. As I said, this is though it's not a gas shadow, but there is a fluid, non-union fluid there. So this is typical of a painful non-union with intravertebral cleft in X-ray and a fluid shadow in MRI, which is the most ideal indication for vertebroplasty. Whether now I think Pradeep was asking this, whether MRI is must before PVP. If there is a typical painful non-union and there is no neurodeficit in lower limbs, it may, I will say it may not be done, because wherever I have presented, people have insisted that you have to do MRI before. So I will say that you have to do MRI before the vertebroplasty. But among ourselves, I can say that in some cases, I do not do MRI and go for vertebroplasty directly. But better if there are any signs of suspicion, definitely. Now, this was a patient who was vertebroplasty I did in another hospital. I insisted that you should do MRI, but somehow that hospital administrator was not very ready to get MRI done. And he said, you go ahead and do the vertebroplasty for this D12 vertebral compression fracture, because the patient was having a lot of pain. The vertebroplasty went on very smoothly. I did it with my 2 pedicle approach, and still the pains persisted, and the patient started developing neurodeficit in about 1 week's time. So MRI was done. And see what MRI is showing. The MRI is showing that it is an infective lesion. The patient was on the kidney dialysis, and that's why the doctor also was not very keen on doing MRI first. The patient was on dialysis with multiple problems, and now see that there is a infective lesion in this D12L1 area. So it is always, you should always advise MRI before doing percutaneous vertebroplasty. If the patient is not ready or something, you may do it without MRI, but you should advise MRI. Now, first tip. Hello. 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 आवाज येत नाही प्रदीप. The first tip is position. You should give hyperextension position in prone position using two transverse bolsters under chest and pelvis, not vertical, but transverse, so that there's.
Incoming voice call from Patil.
Pradeep, bol. Okay, okay. हाच महत्वाचा पार्ट आहे सगळ्यात. ओके. कुठनं कधीपासून गेलं, किती वेळ झाला? चालेल चालेल. अच्छा अच्छा, काय तर जस्ट बोलत. ओके 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 okay 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 okay. Now I think you can now again see it properly. So the MRI, as I said, can put surprises. So it is better always to do an MRI, and you should always advise MRI before PVP. Now coming to the various tips and tricks which I want to share with you for a successful vertebroplasty. First is position. You should give hyperextension in prone position using two transverse bolsters under chest and pelvis, not vertical, because this transverse bolsters will allow the middle portion, the fractured area, to go into hyperextension, and so there will be opening up of the fractured collapsed vertebral body for easy cement injection as well as correction of kyphosis. Now we have seen this very clearly in this exercise, the dynamic exercise, that on extension the collapsed vertebral body opens up. So this should be the position which should be used, and then there should be localization done in lateral position. The second important thing is local anesthesia with standby anesthesis. It is safe in these geriatric patients as most patients are at high risk for general anesthesia. And second advantage of using local anesthesia is that it helps in the verbal feedback from the patient. The patient is awake. If there's any neural element irritation because of posterior cement leakage, the patient will immediately wince with pain, and that will let you know that there's some leakage occurring and you can stop at that step only. If the patient is under general anesthesia, you will come to know this only post-operatively. So local anesthesia is very helpful in for this also. Now, third tip is very important. That is, I have not seen anybody doing that, but I have started using for last nearly 15 years, 2 mm cannulated cancer screw guide wires, which are available with every orthopedic surgeon for transpedicular entry instead of direct entry by the thick J needle. The J needle is the one which I use for cement injection. It is cheaper than other special vertebroplasty needles and all those things. It hardly costs about 1,500 rupees for one J needle, and if you use two, it will cost 3,000 rupees. So these are the most cheap and best options. Usually I use 10 number for lumbar, and about D12 or D11, I may use 12 number J needle. There are certain definitive advantages of using this guide wire before passing the J needle, because having a smaller diameter, there are less chances of neural complications when you are first introducing the guide wire. Secondly, if needed, the track can be modified very easily. I have seen when I was actually in my very early phase of this vertebroplasty, I attended one thing. The surgeon who was demonstrating the case wanted to pass do 3-level vertebroplasty and pass 6 needles, but at the end of the procedure he could only do 1 level vertebroplasty through only 1 pedicle, because all the remaining 5 needles went into different directions and he could not modify the track later on. This is since that time I have decided that I will do only over the guide wires, so that I can easily modify the track, just like what we do in a fracture neck femur. We can easily modify the track if the needle, if the guide wire is not going in proper direction, because we will be first seeing it in AP view, and then we will turning the arm to lateral view. And if we feel that in lateral view it is not going in proper direction through the pedicle, you can always change the direction of the guide wire. And again, third is it has a sharp tip. So in most of the osteoporotic vertebral compression fracture, you can just push it or at the most gently hammer it, so that the feel of the guide wire passing through the bone is very important. If there's sudden giving away, you know that you are going out of the pedicle. So this feel is also very important with the sharp tip of the guide wire. So always use a 2 mm guide wire for transpedicular entry instead of direct entry by thick J needle. The fourth tip is that this is also very useful tip, bipedicle technique. Nearly more than 90% people who are doing vertebral palsy, I have seen them doing so only one pedicle with one needle. But nearly last 8 to 10 years, I have developed doing it by bipedicular technique to pass 2 needles through both the pedicles of the involved body. In the advantage is that injecting normal, here you can see that injecting normal saline. Injecting normal saline through one needle, you can see that it is welling out from the other needle, so that you can really remove the non-union debris from the vertebral body and create space for the filler. Secondly, during cement injection, the second needle acts as a vent, and so you can push the cement without any force easily, and there is a uniform spread. With one needle, usually the cement remains only in one part of the vertebral body and does not spread uniformly throughout the vertebral body, especially when there is non-union. And if there is a unilateral spread, suppose even with this, if you feel that there is a unilateral spread, then you can use the second needle to inject the cement on the opposite side also. The fifth tip is that core biopsy in cases where there is a doubtful diagnosis, or sometimes people say that in every case you do a core biopsy to rule out any other pathologies other than osteoporosis. Once the needle tip enters the posterior part of the vertebral body, then the guide wire is removed. Needle is advanced through this lesion like this. The lesion appears to be here. So needle is advanced by rotating. Now, once you are in the vertebral body, there is no risk of injuring anything. And then you can rotate the needle to 360 degrees, and it has a beveled tip. So it will cut a core of the bone inside the needle. Then the needle is taken out. I sometimes use a external fixator sleeve over the guide wire before I pass the needle, so that it will again guide me in passing the needle after I take out the biopsy. Now, by pushing out with a blunt plunger, usually you get a good core for tissue diagnosis. Sixth tip is, in all cases, nowadays I use a radio opaque dye, that is Omnipack, to assess the posterior wall integrity and check leakages. This is one more thing, biopedicular technique, and this injecting Omnipack has given me zero cement leakages over 8 to 10 years. I always inject a radio opaque dye, Omnipack, to see whether the dye is leaking anywhere, anteriorly, posteriorly, into the intravertebral space or laterally. And once you are confirmed that it is not leaking, then you can inject the cement. And you, as here you can see that I have after injecting Omnipack of about 2 ml, and if there is no leakage, then I wash it off with normal saline. With normal saline, because there are 2 needles, I can wash off the Omnipack from the vertebral body. Of course, it is not very essential. It is a water-soluble dye, but still you can wash it off with normal saline after the. So you have first given the saline irrigation. Thereafter, you have injected the Omnipack to see for leakages. Now, coming to the main important thing, that is the cementing technique. The filler material which is used is low viscosity bone cement. I always use 20 grams of half dose of surgical simplex cement, which is hardly costing 1800 to 2000 rupees. So the total cost, as I said, the needle plus cement goes to about 5000 rupees. There are also alternatives like calcium phosphate or vertebroplasty cement, but they are really quite costly and not needed. Of course, if you want, you can use that calcium phosphate cement, but I have never used it. And the special vertebroplasty cement, at all, if it is not needed at all, the routine bone cement does the function properly. The 7 tip is that for longer working. This is again one more important tip. not only for vertebroplasty, but whenever you are working with cement. Therefore, longer working time, the pre-cooling cement polymer powder and monomer ampule, especially the monomer ampule, I usually keep in refrigerator overnight at 4 degrees centigrade. The pre-cooled cement leads to slower setting, and thus you get a longer working time in vertebroplasty as well as all other cementing work for a bipolar or for any other joint replacement. So it is a very good tip. And you can see these two articles by Chavali and Lai, who have given ice bath for pre-filled cement syringes, and they have found that the cement setting can be prolonged to nearly 120 minutes. Otherwise, if the cement is not kept in the refrigerator, in about 2 to 3 minutes time, especially if the OT temperature is not proper, the cement starts setting. And when you are injected, you want it in a liquid stage. So it is always good to keep the cement monomer ampule in refrigerator. Another important tip is that addition of a small quantity of sterile barium sulfate powder. I get it autoclaved and I add to the polymer. So I take about 1/3 of teaspoonful of the barium sulfate powder, add it, then add the polymer to it. It increases the radio opacity of the cement, and this helps in continuous monitoring while injecting cement to avoid any anterior or posterior leakages. Another important tip is during bone cement injection. This is again what I have developed over the years. I fill a 5 ml syringe when the cement is in liquid stage. It's just setting. I like a toothpaste consistency. We say I fill a 5 ml syringe from the bowl, and then from that 5 ml syringe, my assistant fills multiple 1 ml tuberculin syringes, not the insulin syringe, but the tuberculin syringes of BD, where you can remove the plunger. So for my 5 ml syringe, you can fill multiple 1 ml tuberculin syringes, about 4, 5, and these are used for injecting. So you have seen it here that he is pouring that into a 5 ml syringe, and that from 5 ml syringe, 1 ml syringes are filled, which are used for injecting. Inject 1 to 2 ml each time and push with blunt plunger. All the time you are looking on the lateral view of C-arm so as to see whether there is any leakage or anything. Of course, we are checked with the Omnipack. Still, you have to be on alert, and so check every time whether after pushing whether you are going on. After pushing 1 to 2 ml, push it with a blunt plunger so that whatever cement is there in the needle, it goes inside. Rotate the bevel tip all around for uniform spread. So once you are doing, rotate the needle in all directions so that the cement spreads in all directions. And after some time, once your cementing is nearly over, you can just withdraw this needle from anterior and middle two-third junction to posterior and middle two-third junction, so that you are injecting cement uniformly in whole vertebral body. Usually, you require about 3 to 5 ml of cement, but this bipedicular technique, even I have injected about 5 to 6 ml of cement so that the vertebral body gets filled up nicely, especially the non-union cleft. So the various steps to minimize cement leakages after seeing all these tips are that the needle tip should be seated beyond middle in the anterior inferior portion of the vertebral body. The posterior compacted lamellae, because of the collapse, there is a posterior compacted lamellae. They usually prevent spillage. Injecting Omnipack before cement injection. Slow injection without force, and for that bipedicular entry and keeping the cement monomer in refrigerator are helpful. Constant C-arm monitoring, and of course verbal feedback from the awake patient. That's what I said, the advantage of local anesthesia, verbal feedback from the awake patient. Kyphoplasty in affording patients. If at all the patient is affording and wants, you can always go for balloon kyphoplasty. This was the 2-level PVP case which we saw in the beginning. On hyperextension, I'm sorry you cannot see it very clearly, but on hyperextension, positional kyphosis correction of D12 as well as D11 had occurred. These were the first bipedicular entry in D11, which was vertebra plana, and then bipedicular entry in D12. This is the AP view. Then I have turned first I keep it in lateral view, localize it. Then I take the C-arm in AP view, see the pedicular shadows, pass all the guide wires till they are fixed. And then I turn the C-arm to lateral, and then usually you don't have to turn it again into AP. The next procedure will be done in lateral position only. If the direction of the guide wires is not correct, you can change the direction of the guide wires at this stage. And then the needles are passed over the guide wire. The J needle is usually passed with its bevel tip superolaterally, so that when it is passing inside, if it is medially, it can injure the dura. If it is inferiorly, it can injure the existing nerve root. So you keep your bevel tip of the J needle, and it is very easy to know the rounded portion of the J, which is written on the needle, it corresponds with the bevel tip. So it should be always superior lateral, so that as to avoid injury to the dura or the nerve root. These are the two needles properly placed. And now you can see it here that I am pushing to the D11 saline through the D11 needles, and it is welling out nicely. The debris is getting cleared up, and the space is getting cleared in that vertebra plana, which is D11. And then through the second needle, I am again injecting the normal saline, and again you can see the saline injecting out and the patient wailing. So you can see that the patient is awake. She is wailing with some pain, but usually there is not much of a problem. Only sometimes some sedation is given by the standby anesthetist. So this was the two-level PVP case, D11 and D12. You can see just 4 small needle marks, and no, even I don't take any stitch for these most of the times. And this is immediate post-operative. For D12, it has D11, the vertebra plana, it has spread nicely, and even in D12, it has spread nicely. And after 4 hours, you can see the patient. She was in such a severe pain, but now you can see that after 4 hours, she is walking the slope and steps and comfortably. This is the second case where there was a dilemma of osteoporosis or secondaries. I put the needles from both pedicles, took out the biopsy, and did vertebroplasty. Next morning, the patient who was suffering for 5 months was completely pain-free, and the histopathology report of the core biopsy said that there is no evidence of malignancy. So me as well as the patient were relieved of the anxiety whether it is a secondary or not. This is the third case which we saw where the patient had the difficulty even in getting up from the thing. It was localization which was done. I have got this localizer which is, comes with the destando endoscopic set, but you can use some long K-wire or something for localization. Localization first done in lateral, and then the CM is turned to AP. Bipedicular approach. Final sitting of both needles. Saline irrigation is being done. See, from both needles, I have done saline irrigation, and it is freely flowing out from the other needle. This suggests that both your needle tips are properly placed in the vertebral body, and you have cleared off the debris creating space. After the saline irrigation, I have given radio-opaque dye. You can see that there are no leakages. Then the dye is washed off with a normal saline. The 5 ml syringe is filled up with cement, and from the 5 ml syringe, the 1 ml syringes are being filled up. Now this is the cement injection which is being done. Through both the needles it is done. And this is the patient at the end of the procedure, and good spread of cement. And this is the post-operative X-ray. Immediate post-operative on the table itself. Now you can see that the patient can get up without anybody's support, without any pain. She's still in the operation theater. The cement has set up. And next day morning, she's sitting nicely and walking nicely. A few more examples. 75 years lady, flexion extension. We have seen opening up in lateral extension. 2 needle technique, contrast injection, and this is post injection. And 6 years post vertebroplasty, this lady is coming to me for various other problems, and 6 years post she is not having any problem. This is with this case which I had done 11 years back, where there was posterior leakage. I said single needle was used. Still, this lady immediate post operative, now 8 years follow up, she is not having any trouble and no adjacent level fracture. 66 years post vertebroplasty L2. And one more case, 1.5 years post vertebroplasty L2. To summarize, a few important tips for a successful vertebroplasty are: a fluid cleft or IVC in X-rays and MRI is an ideal indication. Hyperextension with two transverse bolsters, that is a positional kyphosis correction, is important. Local anesthesia for verbal feedback of neural irritation. Use of 2 millimeter cannulated cancer screw guide wires for pedicular entry has multiple advantages, as we have seen already. Bipedicular entry is very important for debris clearance and space created for easy injection. Second needle acts as a vent. Core biopsy in suspected pathology. Radio opaque dye injection to assess for leakages. Addition of sterile barium sulfate powder to cement for increased radio opacity. Usually half dose, that is 20 grams of cement, is sufficient. For longer working time, OT temperature should be around 20 degrees and the cement monomer should be kept in a refrigerator. Use 1 ml tubercular syringes filled from a 5 ml syringe for cement injection. Rotating bevel tip all around and withdrawing the needle at the end of the procedure to posterior 1/3 for the uniform spread. And constant C-arm and awake patient monitoring to avoid any complications. Of course, treatment for underlying osteoporosis must be initiated immediately after vertebroplasty to prevent further fractures. I have got this 10 minutes video showing all these tips and tricks on YouTube. You can always search Dr. Sanjeev Bhandari vertebroplasty and you will find this vertebroplasty video, which will show you all these tips and tricks. Thank you. Thank you very much. So Pradeep, it is about 1 hour. Sorry, but this is a favorite topic for me. And these tips and tricks I have developed over the years. And you use them and I assure you that you will not have any complication at all. And I will be really happy to come and demonstrate a case of vertebroplasty if you have got any, especially with an IVC or non-union at your place.
Sir, thank you, sir, for your excellent presentation.
Good morning.
Yes,
Hello.
Yes.
So thank you, sir, for your excellent presentation. And I have some couple of questions.
Yes.
So which type of bone cement you use? Surgical simplex? Which specific type you use? And what are the advantage of different companies?
There is a half dose surgical simplex which is available, 20 grams. You have to really insist for that. Usually you get 40 grams of full dose. But to reduce the cost and to reduce the wastage of remaining cement, what I used to do in the beginning is that I used to have that 40 gram cement and then take approximately half of it, half of the monomer, but it is not exact. So best way is to get a 20 gram cement, mix it thoroughly. I have never used, there are cost constraints, Pradeep, in our situation in Sholapur, Kolhapur, etc. So this vertebroplasty cement, which costs about 20, 25, 30,000 rupees, or the calcium phosphate cement, I never have any experience because I'm very happy with this surgical simplex 20 gram. So I have also not gone for these other type of cement.
And you inject after 3 weeks. And what is the maximum age after you can inject it? Age of the injury?
Age of the patient?
Injury. So after 3 weeks, you advise for injection.
Patients come after 3 months, 6 months, especially if there is a non-union, intravertebral cleft. Patient will present in about 6 weeks to 8 weeks time because they are having intractable pain. They are not able to do their ADL, that is activities of daily living also. Those who are not having, there are many patients who don't have this non-union, but still pain. They may present after 3 months, 6 months, even I have done after 2 years. It's spread, but not that uniformly, that's it. But the patient gets a very good result, even in those cases after vertebroplasty. And in those cases, definitely do MRI to see whether really there is some intravertebral fluid shadow, etc., which will really give you a good opportunity to explain to the patient that she will get good relief.
So any residents or anyone having any question? Yes. Oh, good. So thank you, sir.
The role of MRI.
Role of MRI. So he said it's better to do MRI if possible.
See, Pradeep, what happens? I will tell you practically what happens.
How many times
These-
teriparatide can be given?
Okay. Sir, another question for Dr. Sachin Firke, sir, our professor.
Yeah.
How many times teriparatide can be restarted?
You can next day. Usually patients say that we will come for the next visit and then we'll start it. But you should insist
Patient.
that
No,
because
no. You see, you are complete, the patient has completed the treatment of teriparatide. So again, after 2 or
Restart.
3 years, if he required, can start again.
So his
Or
question
there are
is,
chances of formation of antibodies, and so many people say that teriparatide can be given only once in a life.
okay, so his question is teriparatide, you have completed one dose. Okay, one dose, complete dose, and after 2 to 3 years, patient is having again same symptoms. So can you repeat the teriparatide, because his concern is it is said that the antibodies are formed against that, and some people may not advocate to start teriparatide again. So what is your opinion?
frankly, I have used teriparatide maximum for 6 to 9 months because patients are really reluctant to take daily injections. Though we advise for 18 to 24 months, and I personally don't have any experience of using it for 2 years, giving a gap and again using it. But the reports definitely suggest what you have said, that it may not be. So that's why pre-treatment with teriparatide followed by denosumab. They had shown that pre-treatment with teriparatide, and then you can give 60 milligram denosumab every 6 months, and that should really increase the bone mass much better.
So how many patients of atypical fracture your patient you have seen? Your treat-
Typical femur fractures. I have experience of 2 patients. To be frank, again, people are not very cautious about this osteoporosis because they don't have. So you advise them bisphosphonate, they take 3 months, 6 months, they disappear, come after 1 to 2 years. They say we have taken for 2 months, 3 months, 6 months, and they have stopped. So those who are taking for 2 years or 3 years, I have only 2 experiences of patients who are having atypical transverse femur fractures. But I have seen on our group and with other colleagues, many have got this type of atypical femur fractures. And if it is a crack, that time only you should do prophylactic nailing.
So I think there are no questions more. So thank you, Bhandari sir, for giving some time for us, and definitely we'll call you for the case demonstration for your technique, and also for the descent if possible. So
Yeah,
thank you very much, sir. Thank you.
Thank you, Pradeep, and all your students and consultants. Thank you very much for the patient listening.
Thank you.
Yes, we can leave.
Yes, sir. Yes, sir. Yes, sir.
Okay.
Chalo.
ये सूरज 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 लिंक चालू रख वो लिंक चालू रख अभी कर दो लैप कनेक्ट कर फोन सूरज यस सर
256 का
512
521
512 यस 512 सर
512
वो देखना पड़ेगा
और ये दूसरा 2020 का मॉडल है ना,
2021 इसको कनेक्ट करना तेरे वापस लिंक से। ये क्यों दिख रहा है? ये तो मेरे लैपटॉप से दिख रहा
इसमें सर
मेरे में